Okay, so this is going to go over chapter 15, which is going over pregestational problems. One of the first things they talk about is diabetes. Um, Obviously, I'm not going to go over diabetes 1 and 2, but you know that you can have it before pregnancy, or it can occur as gestational diabetes, which is where the body cannot produce enough insulin, or there was a deficiency in insulin before, and it was the pregnancy caused a additional need of insulin that the body could not produce. So you can have gestational diabetes. It happens in about 7% of women. And essentially what it is that during the first trimester, the body doesn't need as much insulin, but as you go into the second, third, you're going to need more insulin. And if there was a low production of insulin before pregnancy, during pregnancy, you're going to end up with gestational diabetes. Obviously, the same risks apply that you would have in diabetes 1 or 2 as to gestational diabetes. But we're looking for the fasting glucose now. We were looking for below 99 before. 70 to 99 was your lab value range for most places. But fasting glucose to be about 99 grams per deciliter. And of course, or below that. But of course, you can run your A1C. And the book says 6.5, but I've heard 7, so 6.5 or 7, depending on where you stand at or below is what we're looking for. And again, that's going to measure it over a 3-month span. So it just looks at a cumulative glucose level in the body, or insulin level in the body. So diabetes has, of course, complications with it. One of those when you're pregnant is hydroamniosis, which is basically a lot of amniotic fluid. You have a lot of amniotic fluid, that means you're going to have additional weight. That's one issue with diabetes. And of course, large for gestational age is a really common one. Large for gestational age might end up that the baby is too large to deliver vaginally, and you might have to have a C-section. You also have the risk of cognitive abnormalities. One of these being the incomplete development of the spine and lower extremities, which is almost exclusively in women that are diabetic. Of course, as you get older, you have more risk of being diabetic, or if you've had gestational diabetes or a history of it in your family, then that would also put you at risk. This also causes a respiratory distress. So respiratory distress is caused because the increase in insulin prevents the surfactant to be developed all the way. So essentially, you're not getting enough surfactant because of the insulin, and the lungs don't fully develop. So that's one of the primary things that you look for in a newborn who was born to a mother who has gestational diabetes. Usually they will allow the pregnancy to go full term for that reason, for the fact that the lungs are not fully developed. But there is the risk, of course, of not getting enough nutrients, and we'll go over that too. So polycythemia is essentially where you have too many red blood cells. And when you have too many red blood cells, the undeveloped liver and the fetus cannot properly metabolize those, and you end up with hyperbilirubin, which is going to put a strain on the liver, of course. It's also going to end up that you're going to have jaundice. So basically, the liver simply cannot metabolize all those red blood cells, and you end up with hyperbilirubin. Remember that you're going to need a 300 additional calories per day, and of course they break that down to how many carbohydrates. And carbohydrates are pretty significant to diabetes in general, but especially here as well, because it is a complex sugar. So they want to make sure you're not eating solely carbohydrates as a food source. with gestational diabetes, although you can manage it through nutritional and your regular insulin, they also have um, globulin, which they kind of focused in. Um, it's an oral medication that is used in pregnancy as well. They've determined that that was safe. So going back to the reasons why you might not go to term if you're a gestational diabetic mom, is intrauterine growth restrictions. And this pretty much comes down to the fact that the fetus is not receiving the amount of nutrients it needs via the placenta, especially because there's some changes, vascular changes, vascular occlusions when we talk about this, and it means that the fetus is simply not getting the nutrients it needs and the fetus stops growing. This would be something that you would look at in your BPP or your biophysical profile and could determine that. And of course, if the fetus is not growing, they're going to go ahead and induce labor and take the fetus and then hopefully care for it on the outside. However, most diabetic women go to term. You have lower glucose needs while in labor, and you just want to make sure that snacks while breastfeeding are going to be important because, of course, breast milk has a lot of glucose in it. So also remember during pregnancy, you need 300 additional kilocalories, but when you're breastfeeding, you're looking at even more than that, for 500 to 800 more calories while breastfeeding. Anemia is another thing, so let's get away from gestational diabetes. I'm going to handle the main topics. So anemia is another thing, and of course anemia can be something that you have because it can be a dietary lack of iron or folic acid, or it can also be a genetic thing like sickle cell. You're going to have anemia. But so it's basically a hemoglobin below 11 grams per deciliter. So if it reduces the amount of oxygen you can carry on the red blood cells. Because you are anemic, you have an increased risk of bleeding or hemorrhaging during pregnancy, so that's going to be something that you need to look out for. You want to make sure that you're getting enough folic acid. Of course, that's important for neural tube defects and increased amount of iron. This will result, anemia will result in jaundice in the fetus. It also can cause preeclampsia, which of course we know is a serious for the mother. Fetal hypoxia, just because the red blood cells that an anemic mom has very low oxygen, so that can create hypoxia in the fetus as well, and ultimately result in low birth weight. Sickle cell, like I said, sickle cell is genetic, and it is predominantly in African Americans, and characterized by jaundice, high temperature, obviously low oxygen, red blood cells. They're at risk for pyelonephritis. And of course, because they're at risk for that, you have risk for renal failure. You're also at risk for congenital heart failure, low birth weight for the baby, and fetal death, which is obviously not good. So anemia can be caused by nutritional or it can be genetic, and it would come in the form of sickle cell, jaundice, low O2, low birth weights, and the risk of renal impairment or renal failure. So those are your anemias. Alright. Folic acid deficiency. Any deficiency in folic acid. Again, we take folic acid because of the risk of spinal defects, but the other thing that's going to create is megaloblastic anemia, which means that the red blood cells get extremely large enough because they can't divide. And when they can't divide and they get really large like that, they can't hold oxygen the way it's supposed to. The mother is more susceptible to infection, thrombocytopenia, and of course hemorrhaging, because that's going to be really, you're going to have a bleeding problem in all units. So, fetal alcohol syndrome, of course, fetal alcohol syndrome is caused by the use of alcohol. Anything that a woman takes in that's harmful for herself and the fetus, especially when we're talking about drugs, is going to put the fetus at risk for low birth weight, abnormalities, cognitive defects, heart issues, and withdrawal. Withdrawal would come in the form of irritability, changes in vital signs, things of that nature. So those are all things that you would have to monitor, whether it be alcohol or some other type of illegal drug. And depression is another thing, and I know it feels like we jumped around a bit, but we're looking at anything that puts the fetus at risk, essentially. Depression is another issue, and it affects quite a bit of people, 9 to 12.7%, we'll just call it 13. Of course, you have anxiety, PTSD, and depression. And then, of course, a woman that already has those symptoms are going to go into the risk of postpartum depression, which is serious as well. And then, of course, your very last one, and we're not going to go over all the drugs and their side effects, but the very last one is AIDS, HIV, which they've done a pretty good job at not contracting, because remember, the blood from the fetus and the mother aren't going to mix. So as long as they can be brought in without that mixture, then you have run a good chance of not infecting the fetus as well. So those are your basic ones. Again, anemia, gestational diabetes, drugs of any sort. You're going to have withdrawal, irritability, and folic acid with a major aggressive anemia, and depression. Again, if they were depressed before, then they run the risk of having postpartum depression. And that is chapter 15.